Thank you, Christopher. Good afternoon, everyone. My name is Veronicah Masanja, an alumnus, as I've been already introduced. I'm currently a fellow with the Field Epidemiology track at the Ministry of Health, working together with the US CDC, Malaria School of Public Health, and the Ministry of Health here in Uganda. That is a brief of what I'm doing after my Master of Epidemiology that I just completed in 2020 at the University of Antwerp. Next, Christopher. Yeah, so I will briefly give you a profile about me right now, my academic path, my career path, some of the work I've been doing, and some future perspectives. Yeah, right now I'm a practicing field epidemiologist by virtue of the fact that I'm a fellow. This is a fellowship that was started by the US CDC in 1980, and with the main aim of training field epidemiologists in developing countries. So this was mainly to build capacity of epidemiologists in these countries in order to enable collection, analysis, and interpretation of disease information, so that we can, based on evidence, to make recommendations for action and save lives. I'm also actively involved in research because I'm currently attached to the National TB and Leprosy Program here in Uganda. So I'm doing a lot of work in TB and leprosy, HIV, malaria, and some reproductive health. Some other responsibilities that I've taken on are, I'm a member of the National Health Task Force, also the National Rapid Response Team, and a member of the Palliative Care Association of Uganda. Next, please. That is briefly about my career. I did a diploma in clinical medicine, what in other countries are called paramedics, so I'm a paramedic. Then I did a Bachelor of Public Health at the International Health Sciences University here in Uganda. Then a Master of Public Health, which I'm winding up here at the Uganda Christian University, and a Master of Epidemiology that I concluded in 2020 at the University of Antwerp. Part of my employment as a young paramedic, I started working with the Chiboga District Local Government as a clinical officer, heading a Health Center 3. Then a few years later, I became a senior clinical officer, then left local government and joined an international organization that was working in community health, and that is Living Goods as a branch manager. Didn't take me long to get a promotion to a regional field manager, supervising a number of branches in different regions. That's when I joined my Master of Epidemiology program. That's why you find a slight gap in between my employment history. Immediately after the Master of Epidemiology, I joined the Field Epidemiology Fellowship Training Program here in Uganda at the Ministry of Health. And that I attribute to some of the benefits I got from the Master of Epidemiology at the University of Antwerp. The mentorship received, the skills, especially in data analysis. It is that uniqueness that sold me into this program, however competitive that it was. Next, please. So that is the team that I work with. It includes fellows, the secretariat, and our residential advisor from the CDC here in Uganda. And that was my first day. Yeah, that was my first day. So, yeah. So as part of my work at the University of Antwerp, I was able to, with the help of colleagues, my supervisor and my promoters, I was able to publish my master thesis. That is the trends and correlates of sexually transmitted infections among sexually active Ugandan female youths. because of the encouragements received from the university, most of us were encouraged it would be good to publish. And for me, I'm happy to say that was my first publication. And yeah, it started me on a good journey that I'm headed for. So the recent work, I've been working with my team on a number of projects. My very first project was investigating a malaria outbreak in Iganga district here in Uganda, then investigating an insecticide-treated mosquito net ownership and utilization in Kaliro district. This was following a mass distribution of mosquito nets by the government of Uganda. So we wanted to go and see the ownership and how people are using them, because it is one thing having the nets and another thing using them correctly. Then I'm a national trainer for the catch-up campaign for accelerated TB response for finding missing people with TB. This was born as a result of the impact of COVID-19 on TB-related services. Because of access, there was a very long lockdown here in Uganda, so there was very low access to services, and it affected continuity and also initiation of patients. So there was funding from Global Fund that was put across with a recommendation to hold a catch-up campaign to see if we can find these missing people with TB, and I happen to be a national trainer on that team. We all know there is ongoing vaccination in different parts of the world of COVID-19, and we have seen on social media a lot of conflicting information. So we as epidemiologists or scientists have to come up and make correct some of that information so that we can see our people embrace the vaccination. So I am one of the people that are involved in that vaccination campaign. Because from the information, from the knowledge I gained from my MEPI program, and what I was able to successfully write my first grant on respectful motherhood, and I'm glad I did that. So I also have some ongoing work investigating malaria deaths in 8 districts. When we look at the data, here at the program, we mostly use DHIS2 data, that is the national data that is fed in by different health facilities in the country. So we found a very high number of deaths in some of these districts. So we set out to go and investigate why these deaths are happening at this time. And we are looking at the burden and determinants of latent and active TB infections among inmates in Uganda prisons. I happen to be leading the project, starting with a protocol writing, which has been completed and submitted to the CDC for review. For the campaign that I just talked about, I am heading the assessment of the impact of the catch-up. We want to see if the campaign has been successful in attaining the set targets of finding the missing people with TB, and I am leading that because it's already ongoing. Next, please. More still, we are evaluating the expert MTB reef ultra test guidelines. We all know there are guidelines that have been set for TB diagnosis using the very sensitive ultra test. So we want to assess adherence to those guidelines and also see if there are any differences in outcomes for the culture and STV results for the trace patients that are having 2 results. Because when a patient is found with a trace result, you do another test to confirm, and that's what you use for the test. So we want to see if there are any differences in the initial and final tests. I'm also doing a descriptive analysis, more like profiling the trends in TB treatment outcomes between 2016 and 2020 here in Uganda using DHIS2 data, and also looking at the trends and determinants of missing TB cases in Uganda, still analyzing DHIS2 data. So like I talked about, this is a brief one about the malaria outbreak that we did here in Iganga district. And just to give you a brief history of how we came to determine there was an outbreak. That is my team setting off for our first field investigation. We all know malaria is highly endemic here in Uganda and responsible for 30 to 50% outpatient visits, mostly affecting children under 5 years and pregnant women, and their seasonal patterns, so they vary with seasons. Yeah. Why we went out to study to carry out this study in Iganga district, we received an alert from DHIS2 data on 25th of February. So the way we find those alerts is we run malaria data for a given period of time, and then we use what we call the malaria normal channels, that then we find which districts are mostly affected and how much more the cases are beyond the threshold or the expected numbers, and that's when we determine if there is actually an outbreak. So we identified an outbreak in Iganga district, which is in the eastern region of Uganda. We calculated attack rates to identify the most affected sub-counties in Iganga district, because we couldn't conduct a study in the entire district due to resources. And the outbreak investigation began on the 1st of March 2021. Yeah, from our malaria channels, that is what we do. We calculate the percentiles and see where the highest peaks are to determine which period we shall be investigating in our field investigation. So from this, we can see where the outbreak started, where the highest peak was, and how it progressed over time, and where we started our outbreak investigation. So where we started our outbreak investigation is where we received an alert that there was actually an outbreak for a given period of time in Iganga district that had been consistent. And that triggered the decision to go for the investigation. Next, please. So that is a brief map of Iganga district here with the sub-counties that we looked at for us to calculate the attack rates and end up with one sub-county for investigation. And this is the sub-county that we went to for investigation. It was a full sub-county, but we didn't do the entire sub-county, so we still went ahead to calculate the attack rates for the different villages, parishes and villages in the sub-county, to end up with the most affected for us to focus our investigation. So the objectives, we wanted to determine the scope and magnitude of the outbreak in Nabitende Subcounty and identify the exposures associated with the malaria cases, because we know malaria is endemic in Uganda, and we expect cases throughout the year, but we wanted to know what changed in these communities that led to these spikes in the number of malaria cases. And like I said earlier, with this fellowship, we aim at making evidence-based recommendations for action. So that is one of our objectives. We used a case control study design, and the population were individuals living in Nabitende Subcounty between May 2020 and February 2021. That is, May is where the spikes started. That is why we considered that period. And February is when we detected the alert. So our case was defined as any positive malaria test result using the RDT or microscopy between that study period in the residents of Nabitende Subcounty. Sorry, that is 2021, not 2020, not 2022. So we are, let's go. So what we did was do line listing. So we did a record review from all health facilities reporting to DHIS2 with the aim of line listing our patients the cases that we had defined. And in there, we collected demographics, age, sex, village, parish. We looked at the lab confirmation, was it a BS or RDT we left out the clinical, the dates of diagnosis, and the name of the health facility for comparison reasons. Next, please. So before we generated our hypothesis, we first went out to the field to try and see some of the changes that happened in the community that could have triggered these spikes in numbers. So we had some discussions with in charges of the health facilities. We met community leaders. We met community members. We went for environmental assessment, like you can see in the picture, trying to look for some mosquito larvae, closeness of homes to farm fields, occupations related to breeding sites like bricklaying and what that leaves ditches around. So we went and did all that assessment before we could come up with what are some of the factors that we would include. Next, please. We selected the 3 most affected parishes in Nabitende Subcounty. And from those parishes, we still selected 5 villages with the highest attack rates from the 3 parishes. The households selected, we used from the villages that we selected, to select the households, we used simple random sampling. We had a list of households provided by VHTs or LC1s from which we randomly selected the households using Excel random function. Next, please. So the households we visited, we inquired about malaria in the household member during that period for us to select the actual participants. And from each household, we selected at least 1 case. For households with no cases, we used that as a control. And if there was more than 1 case or more than 1 control, we selected 1 using random sampling by using the first name alphabetic. So we analyzed proportions, we did attack rates, we drew some maps and epi curves, and logistic regression for factors associated with malaria, and all this was used in EpiInfo. It is the program that we mostly use as a fellowship. So those are the cases that we found from that period, and the attack rate for Nabitende Subcounty was 15.9%. Next, please. Click, please. Yeah, so those were the most affected villages after calculation of attack rates. So those are the villages that we focused on for our investigation. And for the risk factors, we found the odds ratios. Kindly click so that we can see the most affected. Yeah, and we found that the most recent political campaigns, because we had lockdown, so people were not allowed to hold campaigns. People were sneaking in the nights to hold small rallies. So there was a lot of exposure to mosquitoes in the nights. Then the waterlogged places, because of the COVID-19, most people lost jobs. So many people went back home to do activities like bricklaying and rice growing. So there was a lot of waterlogging around households. Then the households that were close to swamps and the distance was less than 500 meters, and also distance from the rice fields that was less than 500 meters, were some of the exposures that we found in the communities. Next, please. So those are the factors that I have already mentioned. Next. So we made some recommendations. We realized that we discovered this outbreak quite late, and that is because the districts don't know how to use the malaria channels for early outbreak detection. So we advised that districts be trained in use of malaria channels for early detection. Then mass distribution of treated mosquito nets, because the last had been distributed in 2017. And then also periodic evaluation of the nets, how they are used in the communities. We found some that were using them for fishing, for catching white ants and all that. Yeah, along the journey, both academic and career, there is family. I am a mother first before I'm an epidemiologist. We meet obstacles on the way. With field work, you cannot know what you're going to meet on the way, but you have to push on. We don't only focus on the bad, we also find some hospitality in the communities that we go to. They give us some eats, we play around, and then there is teamwork above all. Who is doing what? Because with epidemiology or with science, you cannot achieve alone. So you need to work as a team. Next, please. Yeah, to my colleagues, especially those that are in first year, second year, or aspiring to join the programs, there are opportunities out there, but it depends on how you package yourself, your skill. How do you stand out? Because everyone else is grumbling for those opportunities. So how do you sell yourself? What makes you stand out? The quest for knowledge. With the evolving nature of science and the world, you cannot stick to just what you have learned yesterday. You have to keep pursuing knowledge. Then the opportunities will never find you seated where you are. You pursue them. Then you have to build networks. It is really, really important to build networks. Networks take you places that you never imagined you would. But above all, our footprints. Let's leave our footprint in the field of science. Thank you for listening.